So my focus for my entire professional career has been in serious mental illness research and implementation. And particularly my clinical interest has been in a population of individuals who have bipolar disorder or manic depressive disorder, which is a mental health condition that's characterized by dramatic mood swings from really, really severe depression to what some people call the opposite, sometimes a euphoria or high spirits. The individuals that have bipolar disorder are often have great potential for being re-entering the workforce or never leaving the workforce, but also on the downside, it's got very high rates of suicide attempts and even completed suicide. It's the #1 disorder associated with completed suicide in veterans. But when it came to the VA, I recognized that people had difficulties in treatment and difficulty responding to medications for much more commonplace reasons than very complicated neurobiology. It was because they had difficulty understanding what medications they were supposed to take, or they had difficult regimens of medications. They couldn't get childcare to come in for appointments. They had no one to call when they were in crisis. And so my own area of research then focused on how to coordinate and integrate care for individuals with serious mental health conditions, particularly bipolar disorder, by pulling together teams of people and using techniques that had been worked on and developed for chronic medical illnesses to see if these same sorts of organizational frameworks could be useful for mental health conditions like bipolar disorder. It was a few years ago that the Office of Telehealth Services, along with mental health services and mental health operations, came to us and said, have you ever done this care model via video conferencing? And we said, no, we hadn't. And they said, would you like to try? And we said, oh, yes, we would. So we partnered with the Office of Telehealth Services to develop care management via video conferencing, and we're now in 6 different VA medical centers across 6 different states across the United States, where we actually implement our program using a psychologist and a psychiatrist, but via teleconferencing, via video conferencing, for doing everything that we would ordinarily do in a face-to-face encounter at the same medical center. So it's very highly acceptable for patients. And it's very interesting also, if you talk with people, more than you'd expect, you'll hear people say, well, you know, I can say stuff to you that I couldn't say if we were in the same room together. I kind of can let my guard down a little bit more because I know that you're there, but there's a little bit more distance. So we actually hear some very interesting things that I'm convinced we wouldn't ordinarily be privy to if we were in the same room. Well, this is a really nice example of how strategic investment in research can translate into real clinical care gains in real time. So we would have never been approached by the Office of Telehealth had there not been an evidence-based underpinning to what we were doing. Working with the individuals, the veterans in the system, has been just a great experience as well. People say, you know, or I say, you come to the VA for many reasons and you stay for the stories, because you just meet so many wonderful people. And it's a great opportunity, and I appreciate the opportunity to give back to people that have given so much for our country.